Hello, good afternoon. I'm Dr. Ponde. I'm a consultant cardiologist at Hinduja Hospital, Mumbai. And today's topic is how to perform an echocardiogram during COVID. The issues at stake are establish the need and indication for a 2D echo. That is the first thing. Estimate the risk to the operator, which could be either a technician or a doctor. Take care of your personnel and train them very, very well. Use of appropriate PPEs depending on the risk of the procedure. And plan the study. That is a thrust on a focused focus. What do you mean by focused? You obtain minimum possible information in minimum possible time and also do a point of care ultrasound, not calling the patient all the way from the wards to the department. A focus will result in capturing 4 or 5 views and 4 or 5 Doppler data in a very quick format of around 10 to 12 images in less than 5 minutes. Scanning protocol should be in place. Reporting should be done from another site and clean the machine after every patient. The indications of our echocardiogram in the context of COVID infection: a transthoracic echo if it is not urgent, then one should wait till the first COVID swab report is available. Once that is negative, it is very easy for us to use the minimum possible PPE and do the echocardiogram. Echo request must be discussed in detail with the treating consultant, because ask him what information is he expecting out of you. Acceptable indications are suspicious heart failure or myocarditis, significant ventricular or supraventricular arrhythmias, significant electrocardiographic changes, 4 more than mild pericardial effusion on a chest CT with suspicion of tamponade, or hemodynamic instability in a previously stable COVID patient. Performance of transthoracic echo should be limited to instances where it would definitely impact on the patient management. That is very important, because if the echocardiogram is not going to add miles into the patient management, it is worthless doing it. The CDC and CSI has called for all elective procedures to be postponed. So when the elective echocardiograms are postponed, one should be sure that by postponing, you should not be causing risk to that particular patient. So that evaluation has to be important and has to be done by a senior cardiologist or a senior consultant, not by a junior resident. Then you should involve a risk assessment protocol in your department. And this risk assessment protocol should be printed, laminated, and put on the wall of the echo room so that every technician can quickly refer to the chart and see the risk of her doing that particular scan. Minimal risk is a patient who is afebrile, who has no recent history of travel abroad or contact with somebody who is COVID positive and has no symptoms at all. So he's level A. He's relatively safe patient to screen even while calling to the department and giving mask to the patient and a surgical mask to the echo technician. Any moderate risk or a high risk patient in this chart. Moderate risk is a patient who has got current fever, current some symptoms like cough, sneezing, diarrhea, etc., and a documented contact with a COVID positive patient or a recent travel abroad. In these type of patients, it is moderate risk. High risk is a confirmed COVID patient. So moderate risk and high risk, the tech and the doctor who is performing in the echo should be wearing a full PPE. Then as a head of the department, we have to also look at the organization of the staff and the capacity. Vulnerable staff members who are elderly, immunocompromised, diabetics should be exempted for doing these scans in this COVID pandemic time. You should discourage or disallow the technicians to come to the reporting rooms. They can just transfer the images on packs and the consultant can view and report them from his own office. So this is a remote off-site reporting. Sometimes even I have reported the echoes sitting at home when the images were transferred to me in the form of loops on the WhatsApp. At peak, one should also do contingency arrangement for another staff member to be available from home. All the different types of PPEs we know. So for level 1 patient, minimally risk patient, a surgical mask will do. For anything other than that, you need a level 2 PPE. The donning and doffing protocols, we have all trained our technicians for doing this. And as an anesthesiologist, you must be all well versed with, so I'll not spend much time in this. The ideal PPE is a PPE which is suited for that particular patient's risk profile. And as I've already said, some N95 masks should be already available in the echo department in case some patient unassured or without an appointment turns up there and who is moderate to high risk. The transesophageal echo should be avoided as much as possible. When I say as much as possible, there will be instances where the yield from the transesophageal echo will be so great that the treating consultant will not be able to defer this procedure or avoid this procedure. At the same time, I must say, in today's world, CT and MRI have emerged as an alternative to transesophageal echo for giving the same kind of incremental information which is helpful in diagnosis and treatment of the patient. For example, if you want to exclude LA appendage cord, CMRI is good or CT is also good. If you want to exclude a large vegetation, then CT is quite appropriate. But there are some instances where the patient may be so bad or so unstable that it may not be very feasible to transfer the patient with an entire equipment to the CT department or MRI department. And then in that case, a transesophageal echocardiography becomes must. Here, in a COVID suspect or a COVID patient, there is no question, absolutely 100% you have to use a level 1 PPE. Echo exams need to be planned before imaging the patient. That is extremely important. Why I'm saying this? Because when you talk to the treating consultant and the treating consultant says, look, Dr. Ponde, I'm suspecting a pulmonary embolism. Then I know that when I start the exam, my echo should be RV centric first. Then quick couple of views of LV, estimate the PA pressure, IVC and come out. So my contact with the patient can be minimized if I know what a treating consultant wants out of me or wants me to focus upon. This is extremely important while doing an echocardiogram. So as an inpatient, we have put one dedicated ultrasound machine, one handheld and one dedicated ultrasound machine for the COVID. That's a Sonosite machine. And we have another machine which is for non-COVID patients, which is a GE machine. All suspected and confirmed cases are to be scanned at the patient's bedside. Don't ask them to bring those patients to the echo department. And then in training considerations, I am passing a small suggestion here that all these patients should be done by very senior sonographer or by a senior cardiology resident at its least. That will minimize the scan time, that will minimize the image acquisition time, and that will give a greater yield for the amount of time and the risk that you have spent doing this scan. So this is on the left hand side, you can see this is our GE portable machine with multiple images, and you can see the console. This console we cover with this plastic which is kept at the below of this second desk of the machine. And this is another handheld GE machine which is called V-scan, which can be literally held in one hand. The probe is very, very small, and you can see the cath lab at its backdrop. This we have put in the cath lab. Here you can simply walk in with this machine in your hand, take it out, and very, very easy to clean. So limited study has to be done. What do I mean by limited study? Basic record 6 views. And I will tell you all those 6 views which are there in my next 8 or 10 slides. One is a parasternal long axis, a standard view, apical 4 chamber, apical 2 chamber, apical 5 chamber, 3 standard views, subcostal 4 chamber, 5th view, parasternal short axis, 6th view. These 6 are mandatory because without these 6, you cannot possibly give any good report about left ventricular global function and right ventricular global function. In case somebody is suspecting pulmonary embolism, then a basal short axis is added, which looks at the great vessels in the short axis at the base. And a subcostal view looking at the IVC is added whenever one wants to look at the volume status. Once these 6 or 8 views, depending on the requirement, are recorded quickly, 5 cardiac cycles each, which will take around 2 minutes or so, then you record mitral Doppler pattern. You record tissue Doppler, mitral annular E prime velocity, takes another 1 minute. IVC dynamic takes 1 minute. and TAPSE along with pulmonary acceleration type takes another half a minute. So in the 5 minutes or 5 to 6 minutes, all these images are acquired, and you simply move the machine out from the patient's ICU cubicle. Clean the machine, doff off your PPE, take the machine back to the department, and do all your measurements and reporting off-site, completely away from the patient's surroundings. That will reduce the exposure of the personnel, the doctor and the technician, to the soiled, infected atmosphere. Another suggestion or a recommendation is, most of the technicians, if you ask them, they do the echocardiography from the right hand side of the patient, which is correct, absolutely, but they have a habit of sitting on the patient's right edge of the bed and then going all across to do the patient's echo. Don't do this, for heaven's sake. You'll have to quit this habit for a long time to come. Please ensure that the patient is wearing the mask. Now this slide will show you that when the patient is wearing the mask, your chance of probability of infection drops down vertically, absolutely vertically. So it is extremely important, not only you, that the patient is also wearing a surgical mask. Wearing the mask properly is important. I will not spend my time in this. And the scanning protocols, as I said, 6 basic images, 5 cardiac cycles each. Then you have 5 Doppler parameters, one by one, preferable right-sided scanning and reporting later. Avoid instructing the patient to take deep breath or do breath holding maneuvers, which we do so very often in doing a routine echocardiogram, particularly for diagnosis of diastolic dysfunction, particularly for seeing volumic status. We do this, but not in a COVID suspect, because if he coughs at the end of deep breath holding or does some forceful, violent Valsalva maneuver, you will be in trouble in contracting the infection. Now, this is a right-sided scan. You can see the patient is looking to the opposite side as what you are. So, the patient coughs or sneezes, the aerosol will go in the opposite direction. Whereas when you are on the left-hand side of the patient, the entire aerosol will come right across your face, which is not required, which is not needed, and which is preferably avoided. Parasternal long axis view. This is the best view to see the left ventricle, the left ventricular size, the right ventricular outflow tract, the aorta, and the lowermost portion of the left atrium, the lower 2/3 of the left atrium. The marker here is towards the right shoulder, and most echo studies begin with this view. You can see this is diagrammatically left ventricular posterior wall, parasternal long axis view, and then there is a parasternal long axis view. It is wonderful actually to see this view, and you can see this clip here. You can see this clip is going beautifully to show you left ventricle, left atrium, aorta, right ventricular outflow tract. This is a parasternal short axis view in which you tilt the transducer with a index mark pointing to the left shoulder, left second or third space. And there are 2 or 3 cuts you can take. One at the level of valves, I mean mitral and tricuspid valve. Second at the level of base of the ventricle. And third, top superiorly at the level of great vessels. Here you can see aorta, right ventricular outflow tract, and pulmonary valve. And here you can see the base of the left ventricle. It's a wonderful view to diagnose pulmonary embolism, where the septum becomes flat and the LV becomes not circular but D-shaped. So it's a wonderful view to diagnose pulmonary embolism. So you can see here on the left hand side, this is the parasternal short axis view, running clip. It's going beautifully. And then the Sachs RVOT view is going also beautifully. Here it shows tricuspid valve, right ventricular outflow tract, and pulmonary valve. So many times you can see a thrombus directly in the pulmonary artery in an acute setting. If you have seen that, you are lucky. You will be able to avoid CT pulmonary angiography. Excellent view. And then you get apical 4-chamber view. Again, right-sided scan. The wire is going, the transducer is going all the way across the patient to the patient's apex, and the index mark pointed to the left. And here you can see 4 chambers of the heart, LV, RV, LA, RA, and you have to see the marker at around 3 o'clock. So the same view, you tilt little upwards and you get apical 5-chamber view in which you open the aorta like this. When you open the aorta, you can see aortic valve, left ventricular outflow tract, and if there is something in the left ventricular outflow tract causing obstruction, particularly in patients with inotrops, you will be able to see that. It's a wonderful view to diagnose left ventricular outflow tract obstruction. And then you get apical 2-chamber view in which you see free anterior wall. Here, the transducer is at the apex. Yes, it is at the apex, but the index mark tilts all the way from the 3 o'clock position, then 1 o'clock position for apical 5-chamber, and absolutely 12 o'clock position to the apical 2-chamber view. And I will show you some examples of this now. This is the apical 2-chamber view. Here the left ventricular posterior wall, basal posterior, mid posterior, apical posterior, and this is the entire anterior wall, apical anterior and basal anterior. Mid anterior you don't see in this view, mid anterior you see in apical 3-chamber view. I will show you that as well. So this is the apical 4-chamber view, left atrium, left ventricle, mitral inflow, right atrium, right ventricle, interventricular septum, and interatrial septum. These are the pulmonary veins at the base of the heart. In 2-chamber, you can see here the apical and basal anterior wall. As I said, the mid anterior wall unfortunately cannot be seen in this view. It will be seen in apical 3-chamber view. So this is the best view, subcostal again, to see the ventricular septum and the RV free wall. RV free wall is best seen in 2 views: extended plaques, which is not the part and package of the COVID echo, and the subcostal. Subcostal is a part and parcel of COVID echo, provided right ventricular dysfunction and PE is suspected. This view sometimes is difficult to get in a ventilated patient. All that you may have to tell the sister assisting the patient to put a patient on maybe an AMBU for a very short while and hold the patient's breath in inspiration, and you will get a beautiful apical subcostal 4-chamber view in maybe 10 seconds or so. In this view, the RV free wall, if it is severely hypokinetic, it is one of the most crucial and very highly sensitive sign of acute pulmonary thromboembolism. In case the RV free wall is moving dynamic very, very well, then pulmonary embolism is almost virtually impossible. That doesn't happen in pulmonary embolism. Now this is another view, subcostal IVC view. You can see a IVC beautifully pulsating and collapsing on respiration. So this is a normal size IVC, which I would say with around 50% collapse on the respiration. And here you can, on the right hand side, sorry, I will pause this video. On the right hand side, you can see if the IVC is less than 21 millimeter and collapsing more than 50%, the RA pressure is around 3. If it is less than 21, collapsing less than 50%, the RA pressure is around 8. And if it is more than 21 and collapsing less than 50, it is close to 15. So you have only 3 categories now. Very simple. AAC guideline 2019. Previously, there were 5 or 6 different parts of this table. Now there are very 3 parts: low RA pressure, intermediate RA pressure, and high RA pressure. That's it. So you can give this RA pressure to the patient and look at this now. You can look at the IVC, get the RA pressure. If you have TR, you can calculate by the peak TR velocity 4V square of the TR velocity. For example, in this patient, the TR velocity is 4 meters. So the RV pressure, by adding the IVC, which is plethoric, by around 20 millimeters, so RA pressure is 20, add into that, the RV pressure comes around 71, something like that. So you get RA pressure, you get RV pressure. Then the next is to see the pulmonary regurgitant jet that can give you pulmonary artery mean pressure. Then look at the mitral flow, E velocity, A velocity. That when you divide by tissue Doppler, E by E prime gives you pulmonary capillary wedge pressure. Here the wedge pressure is close to around 25, very, very high. 33 minus 5 around 8, that is around 25, which is very, very high. So you can virtually give the patient's hemodynamics by these 5 images: IVC, TR jet, PR, pulmonary regurgitant jet, and mitral inflow pattern. So there are several potential mechanisms of acute effects of viral infections on cardiovascular systems. And this is a wonderful diagram which shows that there are 5 direct effects of viral infection. 1, direct vascular infection. 2nd, sympathetic stimulation. 3rd, myocarditis. 4, cytokine storm. And 5, cardiac arrhythmias producing tachycardiomyopathy, or persistent sinus tachycardia of even 2 days can depress ventricular function. You must know that. So again, I repeat, direct vascular infection, high sympathetic tone, myocarditis, cytokine storm, and tachycardiomyopathy. These are the different ways in which heart can be involved in COVID. Myocarditis is the commonest modality that we see even in small or mild cases. Echocardiographic features of COVID mainly include, initially, hyperdynamic circulatory state with hyperdynamic cardiac function and increased cardiac output. 2nd, in 10% of cases, acute Takotsubo cardiomyopathy. In Takotsubo, the base of the heart is small, contracting well, and the apex is ballooned out and contracting less. Right ventricular enlargement with acute pulmonary hypertension is the 3rd way in which COVID patients show you usher their echocardiographic picture. And the last is diffuse myocardial inhibition with grossly reduced LV function, severe global hypokinesia, increased wedge pressure, and at the same time, high SVR. So this is a state usually contributed by severe hypoxia, chronic long-term anoxia. These patients are usually on ventilator, and their CRP levels, D-dimer levels are sky high. So this is practically an end-stage patient. So the association of COVID and CVD, I will not go into this busy slide. I will like to tell you only 3 things you must remember. Number 1, in COVID, the tissue RAS system is hyperactivated by downregulation of ACE2 enzyme. Number 2, in COVID, all the interleukins and cytokines are hyperregulated. There's a cytokine storm in the later stages, not in all patients, in 5% of patients. And in number 3, in COVID patients, there is endothelial dysfunction, endothelial plaque disruption, and microvascular dysfunction as well, producing ACS mimics patients. What do I mean by ACS mimics? These patients come to the casualty not with breathlessness. They come with chest pain, some ECG segment changes, and their troponins are high. And in the initial phases of Italian COVID epidemic or pandemic, cardiologists with great enthusiasm took them to the cath lab, infecting themselves and finding nothing on the angiogram. So please remember that 80% of chest pains in COVID pandemic are ACS mimics of COVID. They are not true acute coronary syndromes the way normally we used to see in atherosclerotic coronary artery disease. So these patients are not to be taken in cath lab. Then comes, of course, myocarditis in the later phase and myocardial severe dysfunction in the last stage. Use of troponin. Troponin elevation assures a bad prognosis. So troponin elevated patients have 6 times more mortality than troponin negative patients. And this slide beautifully tells you, with CVD or without CVD, high troponin has higher mortality. And with CVD or without CVD, low troponin has lower mortality. So remembering this fact, troponin on admission and every 48 hours in a patient above 55 in our country, with or without comorbidities, is a rule in my hospital at least. So the need for echo is subtle myocarditis in all patients. As I told you earlier, pictures in Wuhan showed normal LV function with high cardiac output state and hyperdynamic LV, and there were STEMI mimickers. And if an echocardiographer tells you, my dear friend, this is STEMI mimic, don't take this patient to the cath lab. You need not take this patient to the cath lab. Treat this patient medically. So focus is a focused ultrasound examination of the heart performed by the physician by bedside as an adjunct to physical examination. It's a rapid test. So wherever possible, a senior or treating consultant should be available for this screening, because focus is not the ballgame of a novice. Focus is a very focused cardiac examination, can be done very quickly with the least exposure to the patient. It minimizes staff exposure and conserves the PPE use. And cleaning the handheld focus machine is so very easy that it is very quick examination. Again, 4 basic views of focus: parasternal long axis, parasternal short axis, apical 5 chamber, quick look at the left pleural effusion, quick look at the IVC, lung consolidation if the focus personnel is good enough. I'm sorry to say I'm not so well versed in lung ultrasound, but I'm learning. And at the end of 1 year, possibly 2 of my technicians will be very good because they have been sent for training at 2 good centers and they'll come back with a good amount of training. So structure, image, what do you want to know? Left ventricle, size and global function. If the global function is reduced, you suspect myocarditis. If there are wall motion abnormalities, ACS or STEMI mimic and cardiomyopathy. In right ventricle, size and function by TAPSE. That you can diagnose either pulmonary embolism only, right ventricle is affected, left ventricle is normal, or if biventricular affection is there, it's a cardiomyopathy. Pericardium, you can see only an effusion, or you can see a tamponade which will need a needle drainage or a transcatheter drainage. And valves, you can see gross regurgitation or some pre-existent valve disease. So as the American Society of Echocardiography focus workflow tells you that once you do a focus, then you decide if the focus information is sufficient, stay put. Don't do another echo for 48 hours. If focus examination is insufficient, that is what the consultant feels later, then a proper echo can be done by mobilizing a state-of-the-art portable machine, not the handheld machine. Handheld machine has some limitations. It doesn't have continuous wave Doppler, and it doesn't have a long echo imaging cycle format. You can only record 2 or 3 cycles in one image. Then use of, as I said, transesophageal echo to be avoided. Use either CT on MRI. The problem of CT and MRI in my hospital is the technical hassles in transporting the patient, because our COVID ICU and COVID facilities are another building. So from that building to this building to bring the patient by ambulance becomes next to impossible. But we are getting there. We are raising one more ICU in our main building, COVID suspect ICU. And in that event, we'll be able to mobilize patients faster for a CT or an MR. Again, the CT personnel, technician and the sister and the attendant have to be wearing full PPE, and even the technician who does it and reports, because many times the console is only covered with a glass with 2 big holes in between, with a single AC working for console as well as the patient's room. In that event, you'll have to have a full PPE. Then some anesthesiologist asked me a question yesterday. Dr. Ponde, what about a perioperative TE? See, I am telling you, last 37 days or 38 days rather, we have done only one perioperative, intraoperative TOE, that too in a patient of one of the good cardiac surgeons in my hospital. What happened, he took a patient for an emergency valve replacement. Patient had an infective endocarditis of the aortic valve, torrentially leaking. And he wanted to make it sure that after the valve is replaced, there is no paraprosthetic leak left. Here, I don't think any of us will have a choice. We'll have to go in with a full PPE. Only at the end of the procedure, the transesophageal echocardiography probe is already inserted by the cardiac anesthesiologist. So we go in when the valve is replaced and the patient is coming off the pump, and do quick scan to rule out paravalvular leakage, and that's it, and we come out. So again, least exposure to the patient is very important. And then cleaning the probe post procedure with sterilium. Here there's no question. This probe has to be cleaned with sterilium. For first, it has to be dried for half an hour and then cleaned with sterilium. Machine and ancillary cleaning is very, very important. So if you have what we call a dry time, it is very important. You take the machine out, then dry, then clean it with 0.5 to 1% hypochlorite or sterilium. Either of the two. In my department, we are using 0.5% hypochlorite because it is cheaper, easily available, inexpensive, and most important, it is friendly to the keyboard and the surface of the transducer as compared to sterilium. Sterilium, after multiple uses, can produce some small cracks in the transducer surface. In outpatients, it is even more difficult. But I will not spend much time because anesthesiologists, I think, are not going to do outpatient echo. But here is our echo department. You can see here, AC is on the side of the patient. I am on the other side. Machine is on my side. My attendant is sitting here, and there is a complete plastic partition between the patient and the attendant and the patient, my operator. So the aerosol transmission will be very, very less. He put just one hand through an aperture in that plastic curtain and finishes the echo. The patient obviously has to be wearing the mask. No pillow, no linen. We can use disposable sheets if available. And then once the patient goes, look at my attendant. She's cleaning the entire thing with hypochlorite. This curtain is removed because it's disposable and thrown away. The machine is again, machine's keyboard is cleaned with separate set of gloves. Those gloves are discarded, and then second set of gloves is worn for the next patient. So it is going to be a challenge doing an outpatient echoes in the next 6 to 8 months to come till this whole heat of the pandemic and the virulence of the virus is over. But we are going to be here. We are going to serve our patients. We are going to offer our services, protecting our patients, protecting our personnel, protecting ourselves, and at the same time give incremental valuable information. I thank you for your patient attention. Thank you very much.